Hey everyone, thanks for joining me in session 60 of the Behavioral Observations podcast. This is the much anticipated discussion of sex and sex education for individuals with developmental disabilities. And my guest today, Sorah Stein, is uniquely qualified to speak on this matter, she being one of the few people, perhaps in the world, who are duly certified as sexual educators and board-certified behavior analysts. So we cover a lot of ground in this podcast. Here are a couple of highlights. We talk about the difference between stranger danger and strange behavior. We talk about basic privacy concepts to teach your learners who can determine a learner's capacity for consent, what the essential components are of sexual consent, and distinguishing sexual topography from sexual pleasure. We also fielded a ton of listener questions, and thanks to all of you who took a minute to send those in. We even managed to touch on some familiar topics to longtime listeners of the show, mainly things like precision teaching, the standard acceleration chart, and even our old friends there at Chartlytics. So there's a little bit of everything in here for everyone, I think. Sorah mentioned numerous articles and resources. I have attempted to catalog all of those in the show notes of today's episode. You can find those at behavioralobservations.com at session 60. We're going to get right to the conversation here in just a second. I do want to let you know that this podcast is brought to you by Constellations Behavioral Services. They're looking for folks in New Hampshire and Massachusetts. And what I neglected to say when I talked about them in previous episodes is that if you want to learn more about them, you can certainly go to their website at constellationsbehavioral.com. But you can also go back to I think it was session 39, if I'm not mistaken, where I interviewed the founders of Constellations, Tim and Kim Heald. We're also brought to you by Clinical Behavior Analysis. And again, we've done two shows with those folks, one being session 36 with Brendan Franklin, and the most recent one with the president and executive director, Jason Simmons. So if you want to learn about a cool company with a great organizational culture, you can check them out at cbacares.com. And they will also be at the Florida Association for Behavior Analysis Conference. It's coming up this weekend. So I believe they have a booth. You want to go, just go by and say hello. Say, hey, I heard you on the podcast. If you have any questions about their unique parent training program, I'm sure they'll be happy to talk about that and perhaps anything else. So I think that will do it for opening remarks. So without any further ado, please enjoy this fun conversation with Sorah Stein.
Welcome to the Behavioral Observations podcast, stimulating talk for today's behavior analysts. Now here's your host, Matt Sikoria.
Sorah Stein, welcome to the Behavioral Observations podcast. How are you doing today?
I'm doing good, Matt.
Well, this has been, like many podcast interviews that I've done, something that's taken a while to finally put together. And as usual, the onus is almost always on my account here. This has been a conversation that I believe Dr. Megan Miller has been urging us to have for quite some time. I've had other people request you to come on the show, and I'm really excited that we finally made some time to make it happen. So thank you for taking a little bit of time out of your Friday morning to chat with me. We're going to dig into your area of expertise, or at least one of them. I know you wear many hats in terms of, but I think you're probably best known for doing workshops and being an expert in the areas of sexuality, just general sexuality issues, sex education, etc., particularly with individuals with developmental disabilities. But first, I'd like to start off by asking you how you learned about applied behavior analysis, how you decided that you want to pursue it, and things like that.
If he listens to this podcast, he'll probably hate me for saying this.
Ooh, I like where this is going already.
And frankly, my dear, I don't give a damn.
All right.
It's all Bobby Newman's fault.
Go on.
Yeah, so I started college and thought I was going to be a doctor. I wanted to be a pediatrician or a psychiatrist or something like that. And I needed a job, as many college students do. And I had some background working with kids with disabilities. I've been around people with developmental disabilities since I'm 6. And and I needed to take some college classes, as we all did. And I signed up for this funny class called behavior analysis or something like that. I don't remember the exact title anymore. He probably would, because he forgets nothing. And then I also applied for this job working as something called a shadow for a kid with a developmental disability called autism in a yeshiva. And I had to go to Manhattan and meet this guy named Bobby Newman, who it turned out was going to both be my supervisor while working with this child and, crazy enough, be my professor for this class.
Oh, how fortuitous.
Yeah, well, like I said, it's Bobby's fault.
I see. So this
I
was...
decided that, and then it turned out that chemistry was not my friend. And a lot of those, mathy, sciencey courses didn't do so well for me. And it also turned out that psychology was pretty easy, and that this behavior analysis nonsense that he was preaching was kind of cool and made a lot of sense. And it was easy, and his classes were really easy, and I got good grades. And so I never looked back.
I see. And so you decided to make behavior analysis your career?
I don't think he gave me a choice.
Got it. Where'd you go to grad school?
Also Queen's College. I did my undergrad and my master's at Queen's College, and I'm working on my PhD at Queen's University Belfast. So in some way, shape, or form, I'll have Queens all around me, and it's great.
Very cool. Yeah,
as long as they're not the drama type.
That's right. That's right. Consistent. There's something to be said for consistency, right?
Right.
Is that an online program that you're?
It's not. I get to work with Carola Dillenberger, which is one of the best things ever. And so it's a European degree, and it's research only, therefore. And so all I'm doing is writing a really long dissertation.
I'm sorry to hear that.
Yeah, right. And so I meet with her remotely. But what's cool is it's a research only degree, and so I'm getting to do some really cool research.
Very cool. And are you doing that in the context of the work that you're doing in your clinic?
Some of my stuff does come out of my clinic, yes, and some of it we are, like, one of the studies that's being done is parent workshops. So those are not being done necessarily in my clinic. We've collected data so far from one place where I was invited to speak, and then I'm looking for a couple of more options on where to offer maybe webinar-based parent trainings, preferably outside the U.S., where we can get some pre-test, post-test kind of data on a parent workshop on puberty.
Oh, wow. Very cool. So I realized just in conversation here, we just glossed over probably a couple of decades of work here. Not that we need to go into your Vita, chapter and verse, but I did mention your clinic. And so what is your day job for those who don't know, who aren't familiar with you?
Yeah. So lately it's bookkeeping. With occasionally stopping to plunge a toilet.
What's the saying? Chief cook and bottle washer,
Something like that. Once in a while I run payroll, sign a few checks, Rarely do I get to actually function as a BCBA, it seems like sometimes. But so I live in South Bend, Indiana, which is interesting coming from New York to South Bend. And I often comment about the interesting factors of practicing ABA in a cornfield versus a large city. And so I do have an autism center here in South Bend. We've got 2 buildings, one for our younger kids, one for our older kids and young adults. And then we also provide community-based behavior consultation for all developmental disabilities, not just autism.
I see. And what's the name of your clinic?
Partnership for Behavior Change.
Great. And so how long have you been doing that?
2010 is when I started, and I was my first employee. So I would go to the kids' houses and sit down on the floor and run sessions with them until I had enough money in the bank to hire somebody. So it was one client and then two clients. And at 6, we bought our first building and went from 6 to 12 overnight. And now we're hanging out somewhere around between the two service lines, somewhere in the, 90-ish range.
Wow, that's amazing.
Yeah, we're busy.
I bet.
There's a lot of bookkeeping.
I can imagine. Maybe we can do a follow-up episode on growing a practice. But
no, you do not want to talk to me about that. I'll tell you all the things not to do.
Well, there's value in that, I suppose. But we'll leave that where it is for now. So, as I mentioned earlier, you're probably best known, perhaps outside of South Bend, or perhaps in South Bend too, as having expertise in sex education and et cetera. And I'm probably using the wrong term, so feel free to correct me if I'm. How did you get into that area of education? And I know you have a unique certification in that area, one that I'm not particularly familiar with, and you're probably the only person on the earth who's duly certified. The second, okay, so anyway.
There are 2 of us currently, but there are a couple working on the certification.
All right. So fill the rest of us in on what that entails.
All right, so I'm going to back up just a step there and tell you how I got into this. So I was working on a consult team that the state of Indiana had. And I got this consult for a young adult who was engaging in some problem behavior. And so I go out to meet with the team, and the issue was basically that he had sexually assaulted 2 female staff over a weekend. He stripped, ran through the house, urinated in a flower pot, grabbed one of the staff members by her ponytail, shoved her head down to his crotch and said, "Suck my bitch." Right. And then proceeded to masturbate in a jar of peanut butter. I mean, that's a pretty cool response sequence if you just think about the chain of events that unfolded, right? Okay.
Wow.
So now what was interesting was we're sitting around this table, and South Bend regional area is very conservative. And I have, this 18-year-old staff member who I think if she could have dug a hole under the table and crawled out, she would have. The house manager is a minister. He can't handle talking about sex. The only 2 people at the table comfortable with this conversation were myself and the program coordinator. And everyone else is doing this kind of thing. And so the upshot was, in this case, that the female staff who were working that weekend were mother and daughter. And previously, they came to the conclusion that he wasn't cleaning himself well enough in the shower, and so they were sponge bathing him. And the house manager minister found out about this and said, no, you can't do that. If he needs to learn how to shower, we'll get male staff in here to teach him how to shower. And so this Sunday was the first time that they didn't sponge bathe him. Impressive little extinction burst, don't you think?
Yeah. This is starting to make sense here.
I mean, seriously, increases in, duration, intensity, response, right? Topography. Textbook, right. And so I remember leaving there and going, why was everybody at the table so uncomfortable? Why can't we have comfortable conversations about sex and people with developmental disabilities? And frankly, why doesn't anybody know anything? And so my then boss said, well, go figure it out. Go create a training, go get more education. And so I did. And I started creating a curriculum that was meant to be used here in the state. And it didn't ever happen because they stopped our funding before it happened. But in the process, so I started, working on this curriculum. And then people at the state level got a little concerned. And so my boss said to me, they want you to have some sort of credential. And that's how I stumbled across ASECT, which is the American Association of Sexuality Educators, Counselors, and Therapists. And I found this lovely little old lady named Betty Mooney, who had worked at the Kinsey Institute shortly after Kinsey died. And she became my supervisor, and I went through all of the hoops and stuff to become certified. So the coursework is kind of similar in terms of intensity and breadth as we get in behavior analysis. You've got a few dozen content areas that you have to have so many hours of education in. And then you have to have some supervised time doing education. So the process is kind of similar to becoming a BCBA. And they won't accept all degrees either. So there are some people who are ending up having to go back for second master's degrees in sexuality to get their certifications. Nicholas Mayo is working, I believe, on a sex therapy certification, and I believe Barbara Gross, who works with him, is working on sex education, both through ASECT as well. And then it's interesting because, maintaining the certification is similar to the BCBA as well. My certification is good for so many years, and I have to have so many CEUs in order to maintain that certification. So I'm ending up between the two with something like 55 or something like that CEUs every cycle.
Wow. So you're that almost must be like a constant thing, as opposed to like some periodic burst of attendance of CE events, or at least ideally, of course.
Well, I mean, if I hit one behavior analysis conference and one sex conference per year-ish, I'm usually good.
I see.
And sexual medicine conferences are actually a really good time.
There's so many directions I could go with that. I think I'll just probably leave that there. I've got a friend of mine who is does research in alcohol abuse and things like that, and I can only imagine what those conferences are like as well. But
very dry.
As we used to say in grad school, it's the me search in research. That notwithstanding, what were the acceptable degrees for that certification, or what is it now? I guess there might be some people in the audience who are thinking.
I'm not certain. If people are interested, I would suggest that they go to the ASECT website. It's asect.org.
And how do you spell that?
AASECT. Pretty sure it's .org. Let me double check that actually.
Yeah, and then we can put that in the notes to this program as well. So, all right.
Yeah, it's asect.org, AASECT.org. I know that Frank Cicero, who I love presenting with, is also kind of moving in that direction. There are different programs that you can go to. They actually have a really nice program at the University of Michigan. It's a weekend program. They've got at Widener University some stuff. So there are some different things. And there are some online options where you can get like the majority of your coursework online, but you're still going to have to do some stuff in person.
Clinical Behavior Analysis, or CBA for short, is Kentucky's expert provider of applied behavior analysis, counseling, and direct support services to individuals with intellectual and developmental disabilities, acquired brain injury, and autism. And they're about to open the Center for Behavior Analysis, a 13,000 square foot state-of-the-art facility in Louisville, Kentucky. And they're looking for a clinical director to lead a highly motivated team of BCBAs and technicians. If you're not familiar with Louisville, it's been rated by U.S. News & World Report as one of the nation's best places to live. With a low cost of living, your industry-leading salary and signing bonus will go a lot further. And with an abundance of cultural and recreational activities, you will not lack for fun things to do. So to learn more, go to cbacares.com/careers and set up your confidential interview today. Picking up the story, I guess, before we went on this little detour here. So you started looking at available certifications. You got, you learned about this ASECT certification, and so now you're certified. So let's pick it up from there.
Okay, what's next?
Well, what did you do? Or so what did that? I guess my question is what did that certification enable you to do work in new areas, or were you being assigned all the cases that kind of had some sort of some sort of sexual nature of it, if you will.
Yeah.
And so, in other words, did you become the queen of this kind of, a domain in South Bend?
Well, not in South Bend, because again, South Bend is a pretty conservative place, and we don't talk about sex. Actually,
Well, I grew up as a Catholic in the Northeast, and it's pretty much the same. So,
well, Indiana is still an abstinence-only state, so there's that. But yeah, I guess initially they did give me more of the cases that were related to sexual behavior issues. And then maybe at some point I did a talk with Bobby Newman. I know we did some ethics panels and stuff at ABBA with Peter Gerhardt and some other folks. I presented, on symposia at ABBA and stuff like that. And somewhere along the way, people started to get the idea that I might know what I was talking about or something. I don't know. I'm not sure how it became. I don't honestly remember how people started to get to realize that I knew what I was talking about. It's probably Facebook's fault or something. And you should never believe what you see on Facebook. I don't know how that happened, honestly.
So what? So when you do workshops and give trainings and things like that, what are some of the topics that you find are helpful for practitioners to learn about, and what have you seen audiences resonate with as a trainer?
One topic that I get questions a lot about, and I cover a lot in one of my workshops, is about consent. People want to know what's involved in that, and I know we've got a question coming up on that later. A lot of what ends up happening is I want to make people comfortable with the content and the topics that are involved. Because when people are more comfortable, I think they're at least willing to address. And then I also want people to realize that while sexual behavior is behavior, and therefore we can look at it through a behavior analytical lens, we need to keep in mind that there are other factors in the individual's environment and their personal environment, their private events, that are relevant. And so things like hormones need to get taken into consideration, and biology. And so it's not a simple, EO, ABC, 4-term contingency.
Mm-hmm. So yeah, you referenced some potential questions that are coming up, and what I did is as I usually do, I put out a call for questions to the mailing list, and as you can imagine, this particular topic resulted in, I don't know, a dozen or so questions. So, and a lot of them kind of mirrored the questions I was thinking of asking anyway. So, I think what I'll do is kind of group them in different, kind of topics, because they kind of shook out into a couple of different domains. But I do want to just thank everyone who took the time to write in. Again, I got a bunch of questions here, and I'll probably not reference the actual names themselves. Some people want to be anonymous, and some of the questions I'll probably just kind of paraphrase and group together and things like that. So, so the first kind of domain area in terms of listener questions that came up, and things that I'm obviously interested in too, is the topic of abuse or potential abuse, potential exploitation, and things like that. So let me read a couple of questions here. So one person wants to know how to work on preventing sexual abuse while preserving the ability for a satisfactory sexual life for people with disabilities. She's often met parents that do not want to work around this area. And so a related question is, how to teach stranger danger as well. So if you can kind of tackle those two, what general principles or pieces of advice do you provide when you're doing these trainings or working, in specific case consultation?
Okay, so two things that need to get kind of tossed out. One is stranger danger, and the other one is good touch, bad touch.
Okay.
I know you're a dad, and you probably had those conversations with your kids, and yeah, those concepts need to get tossed out, because here's the thing: stranger danger is a problem, because especially with folks with autism spectrum disorders who take things very concretely and literally, the police officer that they've never met before is a stranger, and we don't want our folks to be wary of police officers or firefighters or EMTs. We want them to accept help from those folks, right?
Mm-hmm.
The flip side of that is a story that actually went around the internet for a while. And, maybe it's not true, because not everything on the internet is true, but the concept is there, that a kid was at one of these Comic-Con kind of conference things, and somebody was dressed as the Flash, and the kid got lost or separated from parents or whatever. And the kid went up to the character dressed as the Flash, this person dressed as the Flash, because the Flash was familiar. But the person was a stranger, and who knows who this person was. And so we need to make sure that people are not learning to be wary of strangers versus familiar people. What we need to be teaching people is to be concerned about or wary of strange behavior.
I see.
Right? Because weird Uncle Harry who smells a little funny might actually be the problem. And the majority of people who experience, especially with developmental disabilities and young children who experience some sort of sexual perpetration, know they're perpetrators.
Yes, I've heard that's true, just kind of writ large.
Yeah. And so stranger danger totally goes out the window there, right? It's weird Uncle Harry who smells kind of funny who you need to be worried about.
I see.
And so what we need to be teaching individuals and children is to be wary of strange behavior.
And so what are there specific behaviors that you teach people to discriminate?
Right. And so then we get into that good touch, bad touch concept, right? And they kind of are going to feed back together, I promise. So good touch, bad touch. We don't want people to be under the belief that somebody touching your genitals is bad, because the doctor sometimes has to examine you, and you might end up with a sex partner one day, and you might touch your own genitals, right? Dave Hingsberger, in one of his books, has a vignette about a gentleman who had scars all over his groin and his penis. And the upshot of that was he had been taught to never touch his penis. And so he was using things around the bathroom to scoop his penis out of his underwear so that he could go to the bathroom and put the penis back in so he could finish up. And he was cutting himself and hurting himself. And so this idea of, that's an extreme example of good touch, bad touch gone wrong. But the idea is it's not so cut and dry, right? We don't want a learner to have the belief that, the doctor can't examine them.
Right.
We want people to have good access to healthcare. So now how do we take that good touch, bad touch that we're going to throw out and the stranger danger that we're going to throw out and come to something good? Well, what we should be teaching kids and people with developmental disabilities is your body is private. Your entire body is private. Right. So again, back to Dave Hingsberger, he has another vignette of a guy who got arrested for touching somebody on a bus. And he said, but I didn't touch her private parts. He had his hand on her thigh.
Oh, wow.
Right? You can't just put your hand on somebody's thigh on a bus. You're going to get arrested for that.
It's going to get,
But
or worse.
Right? But he was very literally correct in that he didn't touch her private parts, right? So now what do we need to teach people? The entire body is private. Nobody should touch me without my permission, right? Yeah. Some parts of my body are special. Okay. And so in that situation, then we do want to be teaching people it's okay for a physician, your doctor, your nurse, your caregiver who's helping you with the bathroom. It's okay for those people to touch your genitals in the right context, right? So it's okay for the doctor to touch your genitals for an exam in the doctor's office. we don't want somebody thinking it's okay for somebody who tells them that they're a doctor to touch their genitals in the bathroom at McDonald's.
I see. So this is like layers and layers of conditional discriminations.
Yeah. Yeah. So when we go to the doctor, at the doctor's office, the doctor is or can touch your is going to or can touch your genitals. It's part of the exam, right? And we can prepare people for that. This is the exam we're going for. Mm-hmm. This is what you need to have happen, and this is why. We need to make sure that all of your parts are healthy. Those special parts that nobody's supposed to touch outside of the doctor's office or whatever, however that story goes, that becomes part of the preparation for a GYN exam or a prostate exam or whatever.
I see.
And when we have folks who need help in the bathroom or with dressing or bathing, so then it becomes around, this staff person is going to be the one who can help you in the bathroom, and this is the way they're going to this is the way they're going to help you. And this is a big deal, and this comes from my friend Charlie Glickman. Everybody should always ask for permission before touching. He has a great blog post on that. And it's not related to our field at all. It's related to just general people touching each other. Massage therapists should ask for permission before starting and forget the whole implied consent you paid to be there.
I see.
Right?
Yeah. So, years and years ago when I was doing man training, there was a kind of a train the trainer thing. And the trainer would teach us and model it throughout, the demonstration of the particular techniques. Every single time there was contact between one person A and person B, he would always say, "May I touch you? Mm-hmm. May I touch you?" And he said it like 1,000 times that week. It seemed like, and that thing, that always kind of stuck with me.
Yeah. And how many times do we touch the folks we work with without thinking about it?
Oh, yeah.
It's a huge violation. And how are we teaching them personal safety at that point? Right?
Indeed. All right. So we got the body is private. Nobody touches it without permission. Some parts are special, and people should ask for permission.
Yeah. And I think that's a good foundation. If we teach people those things, then I think we're at least starting in the right direction, right? And then we can teach the when and where. So, we can teach your bedroom, the doctor's office, not McDonald's, not a public restroom, not the park.
Yeah, that sounds like a pretty good foundation. What would you say? We've got a bunch of questions about kind of prerequisites to learning about these concepts. What's your feeling on that? Is there a particular developmental range or age or what have you? I know it can vary, obviously, based on the profile of the learner and their capabilities, but in your practice, Sorah, when do you start teaching these concepts?
The second they walk in my door.
I see. And so, is this kind of regardless of the? Is this part of what most learners in your program get? Just as part of, or is this I guess what I'm trying to ramble towards here is this the second they get in your door, is that like all your learners, or is this like when you're called in to consult on a particular case as it relates to some sort of sexual issue or somewhere in between?
All of the above.
Okay.
Option D.
All right.
Okay. So you have kids. We had that little kid discussion before us.
That's right. That's right. I am entering teenhood we've been in it for a little bit.
Right. But you have littler ones, and you've had littler ones because the big ones were once little. Do you ever close the bathroom door when you use the toilet, or when you're toilet training your kid, or when you take a shower, or give your kid a bath, or get dressed, or dress your kid?
Do I close the bed? Do I close the door?
You close doors.
Yeah, most of the time, yeah.
There you go. That's sex education. Right? What are we teaching kids when we close doors?
Privacy, basically. The concept of privacy, I would say.
Right. Those open door, closed door discriminations. Right? If I don't have clothes on, my door needs to be closed. I mean, granted, there are some families that are a little bit more free range and sort of like mini nudist colonies in their houses, and that's fine.
That's not us, but
right. The majority of us I think, are a little bit more conservative than that in terms of, public nudity in our homes. So, yeah, I mean, when you start off by closing the door when you go to the bathroom, or when you're potty training your kids and you close the bathroom door, when you stick them on the potty, or when you put them in the bath, or when you take a shower, you're teaching your children those open door, closed door discriminations. That's a sex ed thing, right?
Okay. Yeah, I get it. Yeah.
Yeah. So, I mean, all the kids in my office get that. But here's what's weird is I've worked in so many places over the years. That's not the thing in every place. Like, there were really, I had to have this conversation with a place I was consulting with a few years back. They would have the kid in the bathroom, and the staff person would be standing in the hallway with the door to the bathroom wide open, and the staff person was chit-chatting down the hall with their coworkers. And I said to myself, why is that door open? And I mean, I've had this in more than one place that I've consulted. This is just the most recent one. And I just looked at them and I said, do you pee with the door open and chit-chat with people down the hall? Is this common behavior for everybody who works in this facility? No, you close the door when you go to the bathroom. Get in the bathroom with the kid and close the door.
Yeah, I've definitely seen that in any type of, kind of institutional or congregate living situation. And I think that's just one of the myriad challenges with supporting individuals and those types of
respect and dignity, man.
I know. So it's
close the darn door.
Yeah, that's a good place to start for sure.
So yeah, the kids in my office do get that from the start. We do have one bathroom that's really big and it's easy to get in there and close a door. And the other bathroom is really small. And depending on the size of the kid and the size of the staff person, it's not as easy. And so we just hung a curtain rod over the door frame, like right behind me kind of thing, right? Mm-hmm. Just hung a curtain rod, and we've got an opaque curtain. And so if we need a little extra space, we can keep the door open, but then there's a thick curtain so that the child still has privacy in the bathroom. I see. Everybody passing by doesn't see the kid going potty.
Got it. So we talk about so the prerequisites are basically being human, right?
Yes, yes, so. You get it. Yay!
All right. I took a little bit, but I got it. I'm on my second cup of coffee, so
you're ahead of me.
All right. Do you use any kind of visual supports or references in the context of this type of instruction?
Yeah. So one of the studies that's getting included in my dissertation. And I talk about this one in one of the workshops I give. The individual is now a young adult, but this is going back a few years. And he never closed the bathroom door. He would drop his pants in the middle of a work area and just start to masturbate in front of staff. And we tried all of those typical things like, a verbal prompt and a gestural prompt and a physical prompt and knocking on the door to annoy him until he came over and closed it. And usually that just resulted in him looking over his shoulder and giving us a dirty look while he continued to pee or masturbate. And so what we decided to do was back up the truck there and just teach the discrimination separate from the scenarios that were occurring. And so we used just some match to sample kind of training to teach that conditional discrimination on open door, closed door stuff. And it went through several modifications before we finally found the exact process that worked. Again, it was a Bobby Newman influence that finally fixed it. It was, one of those dumb blonde moments where he just looked at me and I swear I was just so embarrassed. We were teaching, we had pictures of open door body parts and closed door body parts and open door activities and closed door activities, but we only had closed doors. So it was, which one needs the closed door? Great. Which one needs the closed door? Great. Which one needs the closed door? Great. And the kid wasn't getting it. And Bobby came in and just, in his just real simple, approach, just looks at me. He goes, "Where are the open doors?" I'll get right on that.
It's amazing when a supervisor points something that obvious out, how stupid one can feel, or at least I'm just speaking from personal experience, having had that type of moment many, many times. So I totally get that.
And you just feel like such an idiot. You're
it's like, oh man, Of course.
Of course, we're
I'm
the
so
open
stupid.
course.
It's
Yeah.
like the Chris Farley show. I'm hoping people understand that reference.
And yeah, he got it. As soon as he was discriminating both open and closed door behaviors and body parts, bam, he got it. And he now closes the door when he's supposed to. And we did a similar process with another learner. We're attempting it now with a third learner. So that's, something simple. They need to just be able to have picture to object correspondence and I think that's it,
Is this a published study?
Not yet.
Okay.
We'll get there.
I'm just asking because I know it'll be asked.
Not yet.
I have a very inquisitive audience, so
I know.
All right, cool. This is
but
great.
The data are pretty.
I'm sorry.
I said the data are pretty.
Oh, okay. Well, we'll have to keep our eyes open for this to be published at some point or distributed in one way or the other. Or people just have to go to one of your trainings or talks, and maybe you can do.
I do share the data. I do share those charts in trainings.
Excellent.
I have, yeah.
Now, you mentioned the word chart, and I just have to ask. So, are these
pretty blue charts? Standard acceleration
chart. All right. Do you want to take a moment to extol the virtues of that? Like, because isn't that like? Aren't you obligated to do so as a member of the Standard Acceleration Society? Like it's like kind of a rule.
I have
You'll get kicked out if you don't take a moment.
Chart shirt or something. I didn't put it on this morning. I'm sorry, Matt.
Okay.
Sorry to all my chart fellow family. I didn't wear my I Heart the Chart shirt this morning for this chat.
Well, good thing. Well, this is an audio format, so
right.
I think they might grant you some
leeway,
absolution.
Okay.
So anyway, go ahead.
We use the chart. Take data, put it on a chart.
What?
End of story. I don't know.
Okay. All right. So is that when did you? I guess just to take a little bit of a detour away from the main topic.
When did I start using the chart?
Yeah. When did you encounter that, and what about it made sense to you to use?
I did a very brief stint, like a semester at the Chicago school.
Mm-hmm.
And it's Dr. Stockwell's fault that I used the chart. I had to, as part of trying to get into their doctoral program, we were trying to fast track me and test me out of some stuff maybe, and like some master's level courses. And one of the things was I had to prove that I could chart. And so I bought the handbook of the Standard Acceleration chart and figured out, I taught myself how to chart and tested out of a chart class. But then I went to my first PT conference and I was like, hey, this stuff's cool. And then we started looking at it a little bit in my office and started to see how the data display is superior to those % correct things that you create in Excel.
Mm-hmm.
And how the decision-making process based off of those data is a little bit superior. And we never looked back. My staff prefer it. We've been using Chartlytics since it was created. We beta tested the heck out of that thing.
I see.
Yeah.
This was not a planned plug, but for Chartlytics, but that's okay.
But you're getting one anyway.
That's right. Yeah. This one's on the house, Dave. Kidding aside, so what? Do you get down to the level of like pinpointing with the learning channels and the whole nine? So you're just full on head first.
It's interesting because I teach at the State University here in Indiana, Indiana University South Bend, and so one of the classes that I'm teaching this semester is inappropriately called functional analysis. I call it functional assessment, and that's really an intro to behavior analysis. But we were talking last night about the dead man's test,
mm-hmm.
and I do have a couple of people in that class who work in other behavior analysis, autism kind of centers in the area. And they looked at me funny when I talked about the dead man's test and how things like noncompliance are not behavior. And I said, if you start off by like looking at movement cycles and pinpoint your behaviors with movement cycles, that you'll always avoid the dead man's test. And this was like the biggest mind-blowing moment for them.
I see.
So
cool. All right. Well, sorry for that little digression here. Let's get back to the topic at hand.
Well, for your listeners who are either familiar with or are about to be familiar with, because they're going to frantically Google the big 6+6, I do think that those skills are great prerequisites for masturbation.
Okay. Well, let's get into that. Was all right. All right, so let's to use your parlance, back the truck up here for a second. All right, tell us about the big 6+6.
This isn't a talk on precision teaching, dude.
Well, you're the one who.
I was just making a joke.
You said it was relevant, so let's go with that for a second.
So the big 6+6, you've got the they're basically fine motor. So they're
is it like reaching, picking up, things like that?
Yeah. So it's reach, point, touch, grasp, place, release, twist, pull, push, tap, squeeze, shake. Right? Like, how many of those do you use in masturbation? Most of them, right? Just saying. So if you have somebody who's having difficulty with masturbation, make sure they've got their good big 6+6 skills down.
I see.
And throw a lube at them, because that always helps.
All right. So this is very, very granular levels of detail, which is good. All right. So, do we have a masturbation question? I think we do. I'll get to that in a second, though. Okay. I want to talk about, because before we started recording here, we had a discussion of curriculum. Many questions about curricula for these types of issues. So let's see. I'm just kind of reading through them here. Best recommendations for curriculum, best recommendations, what literature's out there, yada, yada, yada. So I think you had kind of like one answer for all of these. So if someone's looking for a curriculum on teaching appropriate sexual behavior, etc., in a DD population, how would you respond to them?
All right. So I think that the Caecus guidelines, there are Caecus guidelines for special education. Those are good in terms of what might your learner need to know.
I'm sorry, what guidelines?
Caecus. Sexuality Information Education Council of the U.S. Caecus.
Okay.
So there are, if you like hunt really hard, there are special education guidelines, not just general education guidelines from Caecus. And they're just guidelines. There's nothing hard and fast about it. But here's the thing. I don't think that anything we do in behavior analysis should start from a curriculum, right? I don't use a curriculum in my office for daily living skills. I don't use a curriculum in my office for personal safety skills or anything else. I meet my learner where they're at, and I figure out what they need to learn, and I teach them what they need to learn. And I approach sex education the same way. So I don't really want to totally jump ahead or out of order here, but you also had something in there from somebody about an individual who's not interested in sex, and should the parents, guardians, whatever, still teach them, right? There's a difference between teaching somebody the mechanics of tab A and slot B or whatever, and teaching somebody personal safety or hygiene or things like that. And, as we just discussed, closing the bathroom door is sex ed, right? And so what does this learner need to know now? What does this learner need to know to be safe in their community, to be safe personally, to enjoy their bodies in a safe and legal manner, right? What does my learner need to know, and how am I going to teach it?
I see. So do you have at least an assessment of sorts, or questions that you commonly ask? I mean, I think you rattled off a couple right there. Would those Caecus guidelines be a place to start? And again, I can dig up that reference and put that in the notes for this episode.
Yeah.
Because that's going to be, if someone's not familiar with this area of work, they might say, okay, I get it. Now I get conceptually what you're talking about in terms of, okay, we don't want to use a cookie cutter approach. We want to, understand where the learner's baseline levels are and then move from there. But it would make sense that there might be some sort of way to determine what their starting points are, particularly if someone is unfamiliar with this area. They might not know what questions to ask or what behaviors to, take data on, et cetera.
So I actually work off of an assessment tool often in terms of ideas. I mean, the truth is most of the time, the need presents itself.
Mm-hmm.
Right? Something happens, a question is asked, the kid doesn't close the door, something like that. And we just move with it from there. A learner says he wants a girlfriend or you name it. So that's one way, is just the need presents itself. The other thing is there's a tool called the Talk SC, TALK-SC. Dave Hingsberger and a very large team, including a behavior analyst, established this really nice tool that's helpful in establishing or determining consent capacity for sex, but also determining what a learner needs to learn. Mm-hmm. So the tool can be used by anyone to determine sex education need. The tool should only be used by somebody with more training, such as a certified sex educator or sex therapist, to determine consent capacity. But it's a really nice tool in terms of determining, especially the knowledge components of what a learner might need to learn in the realm of sex education. Jason Travers just came out with a book, and I haven't seen it yet. I ordered it. I haven't seen it yet, and it's called Sexuality Education. It's on the ProEd website. If Jason put it out, I'm sure it's good. And he has a book on a behavior analytic approach to teaching sex ed and the goals of sex ed, the rationale for sex ed, and some specific issues. It's 96 pages according to the website. So there's definitely got to be some meat in there. But like I said, I haven't seen it yet. I like Terry Kouwenhoven's books. Terry is also an ASEC certified sex educator. She is a special ed teacher by training, and the majority of her work across her career has been working with individuals with Down syndrome. So one of her best books is called Teaching Children with Down Syndrome About Their Bodies, Boundaries, and Sexuality. It's got nothing to do with Down syndrome in particular. It's just a phenomenal book on sex education and developmental disabilities. She also has the Boy's Guide to Growing Up, the Girl's Guide to Growing Up, and I can't remember off the top of my head the one for dating. But those are resources I recommend very frequently. The books are cheap. They're like $15 or less, except for the first one I mentioned. That one's a little bit more. But they're great guides for, talking about body changes and facial hair and erections and shaving and all of those things that kids' bodies are going to go through. And she presents things in a very simplistic, easy to understand way. She's got some pictures that are helpful. And any of those can certainly be used to teach specific topics.
I see. So those resources might provide some. So if I'm just kind of back up a little bit, so in terms of identifying where to begin, the need, as you say, will oftentimes present itself, and that these books that you rattled off of, which I'll put in the notes here, can provide some additional guidance, perhaps, in terms of things to look for.
I love it. I love my job. My name's Alyssa, and I work for Constellations Behavioral Services. I love my job because I feel like I'm making a difference in children's lives. I think the most exciting piece of the job is really knowing that you're going to be able to help people who are really desperately seeking out support. When I'm interviewing someone, I get really excited when people say, I know I don't have all the answers yet, but I'm really excited to make change in kids' lives. I want to research, I want to learn, I want support, I want feedback, I want to see where this field is going. awesome. So I would say someone coming into Constellations needs to be passionate, excited, willing to learn, willing to grow, and willing to come along for the ride.
For more information about job opportunities in New Hampshire, Massachusetts, visit constellationsbehavioral.com/careers. So you mentioned the term consent, and we've got, I know we talked about it briefly, but we have a couple of more specific questions on consent. So one of them is as follows. Consent is a tricky issue even among typically developing adults. What are some of the issues that surround consent for individuals with more significant disabilities? As behavior analysts, what is the most effective way to teach these types of skills to our clients, such as A, how to give consent in a sexual encounter, and B, how to ensure that the partner has given consent?
So this is a topic that I often spend roughly 30 minutes or more on. So we're going to try and condense it real small. There are three components to consent: knowledge, voluntariness, and rationality.
I'm sorry, can you say that again?
There are three components to consent: knowledge, voluntariness, and rationality.
Got it.
Okay. So knowledge is the easy stuff. We're good at teaching information. Behavior analysts know how to teach information. We can teach somebody to spit stuff back, right? We can teach somebody anatomy. We can teach somebody to label their body parts. We're good. Voluntariness, what we want to learn, what we want to look at here is that the person can clearly state that they want to do something in the absence of any coercion. And that would be a big piece there. So you want to know that you've got an individual who has a history of being able to say no when they don't want to do something or don't want something done to them, just as much as they can say yes. So you want somebody who's not overly compliant. Mm-hmm. Just as a sort of aside, compliance is a dirty word in my office. Nobody is allowed to have any compliance goals. We spend entirely too much time making people with developmental disabilities be compliant, and then we wonder why so many of them are abused and exploited in some way, shape, or form. So, nobody is allowed to say the word compliance in my office. But it's true. I mean, going back again, Dave Hingsberger, he has a comment in one of his books about if a person can't say no to peas at dinner, how can they say no to a penis?
Okay. Yeah, that's...
Right? I believe it's Peter Gerhardt who says he aims to be non-compliant at least 3 times a day. And if it's not Peter, I'm sure he has that sentiment, right? But the idea is stop making people do everything you tell them to do. Stop with this compliance training, pardon me, bullshit, because you're not doing anybody any favors. You know, kids should, adults should, do what's needed because we're providing adequate reinforcement and we have a good relationship with them and they want to cooperate with us. And it should be more of a concept of cooperation versus compliance. You're not doing stuff because I said so. You're doing stuff because we're working together.
I see.
Right. And that goes back again to the, prerequisite skills and what are some things we want to teach people. Being able to say no is a really important skill.
Okay.
So that's the voluntariness piece. Now, rationality. What we're looking at here is people who can tell the difference between reality and fantasy. If you've got an individual with behavior history of that, what do they call it? False allegations, mm-hmm. That would be a red flag. You don't want somebody who's likely to come back after having given consent and said, oh, my significant other assaulted me. I didn't really give consent. That kind of behavior topography is a red flag for the rationality part. Somebody who is, while we might all fantasize of our favorite movie star coming and picking us up in a limousine on our birthday, the person who is really of the belief that their favorite movie star is coming to pick them up and take them in a limousine on their birthday, again, a red flag on the rationality piece in terms of giving consent. So you need to have all three criteria, all three components there met in order for somebody to be able to give consent. And going back, that Talk SC actually addresses all three and indicates which of the three any particular target addresses.
I see. And just to be clear here, that is going to be administrating and interpreting. That's going to be outside the scope of practice of many
For
people
education, yeah. So for education purposes, if you are merely looking to see what does my learner need to learn, anybody can administer. If you're looking to administer it for the purposes of consent capacity, that's outside the scope of most behavior analysts.
Got it. So related to consent, let's say there's what's been your experience with the dating scene for individuals with developmental disabilities? I know we've got one question about that. The rules of dating are pretty gray and difficult for folks to perhaps navigate, particularly individuals with developmental disabilities. What are some common challenges, and perhaps what are some solutions that you've seen that have been effective?
Yeah, I haven't mastered it myself, and so if anyone has any tips, I'm happy to take them. You can send them my way.
Stein, Sorah at. Well, we talked earlier about like learning from mistakes, right? So
Don't even go there, Matt. I think that the organizations that do like socials that are monitored, maybe mediated by staff, that's not a bad idea. I think it's difficult for people with developmental disabilities to meet appropriate potential partners. We've got a young man now who's just transitioning to college this semester, and we're providing him some support in that realm. And he's very concerned about finding a girlfriend. And it's funny because when I saw that question, I actually sent it to the BCBA, who most directly works with that learner. And his response was, I'm just as confused as he is. So like I said, I haven't mastered it either.
The struggle's real, as they say.
Yeah, right. I think the best, what is it? The Dr. Seuss thing about falling in love is finding somebody just as weird as you are and compliments your weirdness or something. It's a Dr. Seuss quote. So I think that providing safe opportunities for people with disabilities to meet other people is always a good idea. Providing opportunities for people with developmental disabilities to practice the social skills that would be needed. I had a phone call a few years ago from an adult with, at the time, Asperger's in my community here. And he was very concerned because he said he likes to go out dancing, and his goal is to meet a partner, but he likes to go out dancing, and he's always very concerned, like to the obsessive point, that he's going to accidentally bump into a woman and she won't be consenting to being touched. Mm-hmm. And so he spends so much time talking to people and saying, if I bump into you, I apologize in advance, or is it okay if I dance near you and I might bump into you? And I said, you know what? I think you're on the right track, buddy. Better that you should be a little overcautious than, inadvertently offend somebody or hurt somebody or, but he said he finds it very awkward to have these conversations. And I said, everybody does, right? Nobody is, the people who are super smooth, like worry about them. Because there's probably something wrong with the fact that they're that smooth. I think that most of us struggle with that. And I think the biggest thing is that we probably need to work on teaching the skills to be safe and discriminating, who, you see this on TV shows once in a while where somebody is shocked to find that their date is charging them $300 at the end of the evening. That naivete we need to be worried about. So I think that we do need to teach people ways to discriminate, a safe potential date versus a prostitute. And I think that if, you can figure that out for yourself, then you can probably teach it.
I see.
You probably shouldn't pick up somebody on a street corner. That's probably just a good safety rule. I mean, in South Bend, it's usually not that big a deal. But, in general, you shouldn't be picking up people on street corners and going and having dinner with them, because the likelihood that they are going to charge you afterwards is higher.
It is funny. We did get a few questions about prostitution.
I know. Yeah. Yeah. But again, I mean, if you can discriminate it, break it down. How did you discriminate it? Right? What are the things that tell you that person is a prostitute versus they're a viable date? If you're finding them on Craigslist, be wary. If you're finding them on a street corner, be wary. If they're calling you over on the street going, "Hey, baby," be wary. But if you met them through friends, or you're both, sitting at the symphony, or I don't know, like maybe you've got something going there.
So again, I'm kind of I'm thinking again some sort of conditional discrimination. These are good places to meet people. These are places that maybe not so much.
Yeah. Again, think about how you met people. I know that at least one person I know who submitted a question related to that met his wife at a ABA conference.
I'm sure there's probably many people who would fall into that category.
I mean, maybe that's not the most practical way for some of our learners to meet their spouses. But the idea is, again, going back to the idea of organizations having social events. That is a way for them to meet people.
Good to know. So we got one question that went way, way, way into detail about an individual who, and I'm going to kind of spare the details here, but long story short, individual has a repertoire of some pretty significant challenging behaviors, significant deficits in, toileting skills, et cetera, probably not, I'm going to infer that, it's not safe to leave alone at certain periods of time. But at the same time, there's a lot of, what we might call, sexual behavior going on in terms of, rubbing his groin, on objects and things like that. And so this person is confused about how to proceed in terms of teaching, healthy sexual outlets and so forth, given the safety concerns of this, this other repertoire of dangerous behavior. And so what I don't want to do is have you play behavior analyst, via Skype and assess and diagnose and treat, of course, and give specific recommendations. That's the last thing we want to do. But I guess my question relative to this is, what are some principles that this person should consider, and possibly, if available, what might be some resources that this person can look up, or people to reach out to, or what have you, because it sounds like a pretty hairy situation.
Yeah, but not one I haven't heard before. So in that situation, there are a couple things going on, actually. Number one, all right, so I got a call a couple years ago from one of my colleagues in Atlanta, and he said to me, he goes, "I need to run a scenario past you, and I know I didn't ask a question that you're going to ask me. So I'm going to give you the information, and then I'll get the answer to that question." And I said, "All right, what do you got for me?" And he said, "Well, I think it was like a 40-ish-year-old gentleman who very, very low cognitive functioning, non-vocal, and living in a group home, and they wanted a sex educator to come in, and that blew my mind." Anyway, so what was going on was that this gentleman was, to use their term, humping the floor.
Mm-hmm.
So he was laying face down and pressing his abdomen and genitals into the floor. And what was interesting was it only happened in the kitchen. Okay, so that to me went, interesting. And I said to Mitch, "All right, what am I going to ask you that you didn't ask?" And he said, "What medications is he on?" I said, "Bingo." And so he called me back a little bit later, and the man was on 7 different medications for constipation.
Wow.
And I said, he doesn't need a sex anything. He needs a gastroenterologist. I said, they need to rule out medical. Now, why was the kitchen floor interesting? Because the rest of the house was carpeted.
I
so
see.
he had a harder surface on the kitchen floor. They went to the doctor. The guy had a bowel impaction. They fixed that. He stopped humping the floor. Was it a sexual behavior? No. He had belly pain, and getting the pressure from the floor up against his belly was alleviating the pain related to the bowel impaction. And as soon as they got rid of the bowel impaction, this behavior went away. Now, was the topography something that could be sexual? Yeah. And so what I always tell people is that they need to distinguish sexual topography or a behavior with a sexual topography from behavior that results in sexual pleasure as a reinforcer. So in the case that this person's question relates to, number one, I think that they do need to rule out any medical issues, especially because that particular question, when you sent it to me and I looked at it, it seems like some of this is either new or increased. So anytime there's a new or increased behavior, we do want to look at making sure the kid doesn't have an ear infection or strep, right?
Sure.
And in this kind of a situation, we want to make sure that the person doesn't have a urinary tract infection or a kidney infection or a bladder infection or psoriasis or eczema on his penis or a blocked ureter or a bowel impaction.
I see.
Okay.
Yeah, obviously, good place to start. It seemed like it worked out well for the gentleman that you were consulting on.
Right. The other piece is Dave Hingsberger has a paper on coprophilia, and that would be the fecal stuff. Mm-hmm. So fecal smearing is its own behavior, and I would look at, what's the function and find a replacement. But in Dave's paper, and it's an oldie, it's like a 1980 something or other date, the individual was actually using the feces as a lubricant. And so what I would suggest is, and I suggest this all the time, give the guy a lubricant. Always give the guys a lubricant. Everybody will be happier if you give the guys a lubricant. Women produce their own, guys do not. And so what you're looking at is there was a study that came out of Indiana University med school, Bloomington combination, and Dennis Fortenberry is one of the authors on that paper. Really neat guy. And what they found, and this was just like one of the sub things that they found in their study, was that lubricants increase the sensitivity of the penis. And so a guy is more likely to be successful if he uses a lubricant because his penis is going to be more sensitive. But also when stuff is slippery, your hands are going to more naturally move in ways that produce those good feelings and get you where you need to go.
Got it.
Okay. So always throw a guy a lubricant. I'm not a big fan of KY and Astroglide. There's something called Good Clean Love that they sell at Target now. I used to only be able to get it online, but it's now available at Target. Far better lubricant. But often that fixes a lot. Now, there are some guys who need to be taught how. If there's a video modeling history, I like the video Handmade Love. That's also a Dave Hingsberger thing. There are some videos on a website called sexsmartfilms.com.
Okay.
As a sex educator, I'm actually not allowed to have physical contact with my learners, so I can't do something like hand over hand. That said, be super, super, super wary of anybody who's jumping to do hand over hand masturbation training. Frank Cicero's line is there's a fine line between helping someone masturbate and masturbating someone.
Okay, so I'm going to ask just kind of an ignorant question here. Like, are there people actually practicing that?
Terrifyingly, yes.
Okay, I'm a little speechless at that.
Yeah, I see that. I was just about to tell you to breathe.
What? That's crazy.
Welcome to the wide and wonderful world of ABA, Matt. It's a scary world out there. I'm sorry.
Hand over hand. Oh, my God. All right. Well, I was just going to ask the question, what's the most awkward conversation you've ever had about sex with a client? So let's
You might have had it.
I think we just had it. Yeah. Anyway. Yeah, actually, are you able to answer that question without giving in a way that jeopardizes the privacy of the individual?
Yeah, I mean, I think the one that I started off with the masturbation and the peanut butter scenario goes up there pretty high.
Yeah, that's pretty unique.
And what was great about it was right about the time that there was that recall on peanut butter because of salmonella. So that just made the whole scenario even better. And I remember asking the team if the individual masturbated, and they said they weren't sure. And I made some comment about, I would think the evidence, one of those would be apparent. And somebody at the table goes, well, the proof would be in the pudding. And I said, no, it would have been in the peanut butter. Another one that came up, and it's one of those things where you just kind of have to remember that people just don't know lots of stuff sometimes. I had a call or an email, I think it was years ago, from a mom whose preteen, early teen son with a developmental disability was masturbating in class. Clearly didn't have those open door, closed door discriminations down, and was probably really bored. And the teacher had the brilliant idea to put a piece of Velcro under his desk and told him if he needed something to play with, he could play with the Velcro. I'm not sure that helped the situation very much, because I did still get the contact from the mom.
I see.
Yeah. I don't think it was that he was looking to play with something in general.
Right.
Yeah. More of the idea of the built-in toy that's really fun. Are there any other really funky ones that I've had that wouldn't give away information? I've had some scary-ish ones that I've seen at presentations where, again, it's very clear that people don't know, laws of consent, or people don't know what's involved in capacity to consent, or what actually needs to be taught and doesn't need to be taught. And people aren't doing proper assessments to determine what behavior modification approaches should be used, and they're making assumptions. So a lot of the, and pet peeve of mine, but a lot of the Facebook consultation
Oh, yes.
is, it's very clear that people make the assumption that behavior that has a sexual topography must be automatically reinforced.
Mm-hmm.
Not always the case. Right? Partnered sexual behavior is not only automatically reinforced, right? There's some socially mediated reinforcement if you've got a sex partner.
Right.
If you're having sex with yourself, then yeah, it's probably completely an internal thing. However, there could be, other stuff like escape from task demands. Because if I drop my pants and start masturbating, people probably aren't handing me paperwork to sign.
Yeah. And it would generate some amount of attention, more than likely.
Right. Now, if I'm masturbating by myself in my bedroom, now I might say, yeah, probably not so much socially mediated. But, I had a situation, I don't know, maybe about a decade ago, where a teenage boy and a school bus. So for many years, he had the same male school bus driver, and he would get on the bus, and his routine was he would get on the bus and reach across the bus driver for the little handle that closes the door, and he would pull the door closed.
Mm-hmm.
Okay? So he's reaching across the driver and pulling the door closed. Well, that male driver went out on, sick leave or whatever, and there was a female driver that was replacing him. And he told the female driver ahead of time, by the way, this is the kid's routine. So she was prepared for it. This was a very buxom female bus driver. So when he went to reach across her to grab the handle and come to close the door, he grazed her breasts. She freaked out, which apparently was very amusing.
That's good.
So what happened? So what do you suppose happened the next day when the kid got on the bus?
Right. He went to that well again.
To
Yeah.
do something that made her freak out again. Was it a sexualized behavior? I mean, he wasn't aroused. He didn't have an erection. He thought her reaction was hilarious, and he got kicked off the bus.
I see.
And so I think it's important that we determine, is this a behavior that's a sexual topography, or is this individual aroused or otherwise having sexual pleasure as part of their reinforcer? And sometimes it's both. I had a situation in a high school. I really had to channel my inner dumb blonde for this one. So teenage boy, autism spectrum. Every time he gets handed a math sheet, he grabs his paraprofessional's breasts and flips the table and trashes the room. Okay. And I said, well, what happens after that? Well, he has to go to timeout.
Yeah.
Okay.
That'll fix it.
Right. And I said, well, what does the timeout room, what does that look like? What does timeout look like? Well, we have a room over there in the corner with a door. And I said, okay. And, how long is he there? Oh, usually a few minutes. Okay. And what does he do while he's there? Well, he does what boys do. I said, you mean he masturbates? Okay. So let me get this chain straight. You give him a math sheet. He grabs somebody's breasts, flips the table, and gets excused from the classroom to go to another room where he gets to masturbate. I think I'm stumped on this one.
That's right. Well, it's funny. It just kind of reminds me of Greg Hanley and others' work on synthesized reinforcers. That's like the whole shooting match right there. There's escape, there's attention, there's access to self-stimulation, all in one.
Right. So I made the dumb suggestion of, well, could he get access to the timeout room if he finishes his math sheet? Yeah, that was apparently the stupidest thing they'd ever heard. Well, we can't do that. What do you mean? Well, we can't give him permission to go to the timeout room. But what are you doing now? Yeah, that consult didn't go over real well. But so I do want to make one point, though, that people don't always realize this, that arousal, sexual arousal, like having an erection, sexual arousal, the increased blood flow to the genitals, both for the people with vaginas and people with penises, that alone is a reinforcer. You don't have to get off for sexual stuff to be a reinforcer. Arousal alone is a reinforcer.
Got it.
It's not a terminal reinforcer. But I mean, for guys who are like 45 and up, I mean, come on, getting an erection can be a reinforcer, right? Your facial expressions are priceless, Matt.
I'm so glad this is audio. So glad
your
this is
facial
audio.
expressions are the best.
Oh my god! So
how much of this are you editing out?
No. This is we're gonna let this fly, Sorah. I'm an open book.
So I mean that's something to consider though, and that is something I ask a lot when I'm doing consultations. Is okay, I get that this behavior is happening, but part of what I'm trying to tease apart is this a behavior that has a sexual topography versus is this a behavior that has sexual pleasure as a reinforcer? And so I do often ask, like, is there visual arousal? Like, can you see that there's arousal?
I see.
And if not, then I'm looking at other things going on. Now, obviously, with people with vaginas, that's a little bit harder to determine.
One of the things I'm curious about is when you go to, say, like a sex ed conference, right, and you're hearing people perhaps present cases, I have to imagine being a behavior analyst must be like having like a superpower, and it's like, I mean, I could kind of picture you in the audience saying, well, duh, they're doing that because of, fill in the blank function, does that happen?
So Bobby Newman actually has a story about that one. And we actually just discussed it yesterday. There was some presentation he was at, and the person completely missed the fact that the individual had a fetish. And it was a behavior analytic presentation, and the person completely missed that there was a fetish and that it was influencing the whole topography of the behavior and the function. I think that there are times it goes both ways. I think that there are times that I have been at behavior analysis presentations and gone, you need to learn anything about sex. Or you're totally missing the point here. Or even just in research, even at just the last ABAI conference, I don't remember what the presentation was, but there was something related to delay discounting. And I went up to the presenter afterwards, or maybe just asked the question, and something about, did you look at menstrual cycles of the women in the context of your delay discounting study? And they were like, no. Well, yeah, because estrogen affects our ability to delay discount. So that would be highly relevant. And they just looked at me like they had no clue. And yeah, I've definitely done the same thing at sex ed, sex therapy conferences. And I don't go to those a lot because their concept of science is a little bit weaker than ours. I really like the sexual medicine conferences instead, where the majority of the folks I'm sitting with are physicians and hardcore neuro researchers. Those conferences are a lot more educational for me.
I see.
And I don't get frustrated nearly as often and think to myself, my goodness, you don't know anything about human behavior.
Well, I'm glad you made the point in reverse, because it's important for us as practitioners to know what we don't know, and to know when to ask. Perhaps, and I think Mark Dixon said this on the program many sessions ago. We don't have the lock on all the smart people, so. That's a great point to bring up. So thank you for doing that. Sorah, this has been about almost an hour and a half that has kind of flown by. So I've definitely learned a lot. And I'm sure we'll get some follow-up questions and things like that. So I might ask you to come back. But in the meantime, as we kind of bring this chat to a close, what advice would you give to a newly minted behavior analyst, someone who just got their BCBA? They're out either in their new job or looking for a job, and they're in that stage of their career, in the beginning of their timeline, if you will.
Two things. First of all, you probably don't know nearly as much as you think you know. And Facebook is not an appropriate method to access clinical consultation. I would not feel comfortable if my rheumatologist was posting on Facebook to get information on a case. And I don't think that's where behavior analysts should be looking for information on a case. I think it's okay to maybe post and say, hey, I need somebody with expertise in X, Y, or Z, and get some names, and then reach out to those people individually. But we should never be posting any kind of clinical information in a social media forum to get help to fix a problem or solve a clinical situation. I think at the same time, to just sort of expand on that slightly, there have been postings recently. There are a couple videos that have been particularly bothersome to me. One is this kid who's being forced to communicate. It's not even communication. And the kid is like bawling and trying to get out of a hold and all this other stuff. And they're talking about how, facilitated communication is changing this kid's life. And you kind of want to puke watching it. And the other one was an individual engaging in some significant self-injury. And the video is about how cannabis changed her life. And my question is, why the hell is this on social media? And what happened to people's right to respect and dignity? And would these people be consenting to these videos being plastered all over the freaking internet? And so I think, in addition to, thinking about HIPAA and things like that, we have to think about respect and dignity when we're posting and asking for clinical support in a forum that, has 10,000 people looking at it.
Indeed. I did not see the first video, but I've definitely seen the other one, of the cannabis one, and just even looking at the comments, like, you could drive yourself crazy, it's and it's just, but I would echo the, if you do need help, and I've done this before, and say, I'm looking to connect with someone who has experience in fill in the blank.
Yes.
Please,
that.
please PM me,
Yep.
and I've, that's led to some, really great help on my part, and things like that. And you can, vet that advice giver, in a little bit more detail, rather than, getting the, the peanut gallery to respond. So, yeah, I mean, I think I've seen, I think it's getting a little bit better. I don't know if maybe I'm just kind of limiting what I'm looking at more. Okay, you're saying yes. All right. I have seen people kind of police it a little bit more. When someone puts up a post with lots and lots of detail, I've seen group members say, hey, that's quite a bit of information there, or some other.
Well, especially because we can see where people live on Facebook, right? I mean, I can go back to the original poster's page and I can see where they live. I might be able to see where they work. And now if they're telling me that they've got a 14-year-old engaging in XYZ behavior, and I see that they live in Podunk, well, you know what? There's not a whole lot of 14-year-olds with autism spectrum disorders who are girls who live in Podunk. And you know what? I might know that kid.
Yeah. Yeah, I mean, Amanda Kelly came on. We did a full episode on this, so it's definitely an issue that that needs to be revisited constantly. Oh, looks like your cat is basically saying the interview's over.
Yeah, she's petting me. That's her way of demanding to be touched. And
I see. It's very effective, apparently. So
it is a very effective mand, mostly because it's negative reinforcement for me, because I can't stand her petting me.
I see. Well, Sorah, this has been great fun, and I think what I'll do is let you provide full, undivided attention to your cat there, and we'll have to do this some other time. Thanks so much for
my pleasure
teaching us about this area where many of us are quite confused.
Thank you for listening to the Behavioral Observations Podcast with Matt Sikoria. You can find Matt's notes on this episode at www.behavioralobservations.com. We also invite you to stay connected with us on Facebook at facebook.com/behavioral observations and on Twitter at Behavior Podcast.